So what is cannabis, right? So people talk about cannabis this, cannabis is legalized, and really what I like to say is cannabis is not cannabis, meaning that it's such a diverse plant that it's really hard to talk about, give it one label, because depending on how it's grown, depending on how it's extracted or used, it can have such varied effects. So, using this term cannabis is rough from, when you start talking about therapeutics, and I'll get into why that is. But we know that the cannabis plant has over 120 individual cannabinoids within it, or what we call phytocannabinoids, because they're from the plant. The most common thought about studied one is THC. You guys have probably heard of that. That's delta-9 tetrahydrocannabinol. That's where the majority of the research has been to date. THC is responsible for getting high, right? When you use typical cannabis that you get off the street or from a dealer or whatever, when you get high, that high is because of THC. CBD, cannabidiol, is the second most abundant cannabinoid found within the plant. And it has very, very different effects from THC. We'll talk a little bit about those as we go through, but an example of this is anxiety. High amounts of THC can actually increase anxiety, whereas high amounts of CBD can actually decrease anxiety. So just again showing you the importance of, when you talk about cannabis, it can have very different effects depending on the parts of the plant that are in there. Research on CBD is really catching up. It's all over the press, right? A lot of the stuff starting with Charlotte's Web and all the epilepsy stuff that was out there, Time Magazine, Newsweek, etc. These increasing attention because of individuals that started using CBD for different conditions. That said, most of the research on CBD has really been within the past 5 years or so, 5 to 10 years, not a whole lot, and we still are trying to unearth the mechanisms underlying its effects. Different from THC, which has very direct mechanisms of action and targets CB1, cannabinoid 1, and CB2, cannabinoid 2 receptors in your body. CBD does not. It kind of scatters serotonin, TRPV1, all sorts of different things in terms of mechanisms of action. So still trying to figure it out. And that's just 2 of 120 plus, right? So I just threw up a couple up here. Tetrahydrocannabivarin, something completely different, cannabigerol, cannabichromine, cannabinol, it just goes on and on and on. And these all have very different effects. So it's a very complex plant to study, and it's hard to think of it as a single drug. It's really a combination of tons of drugs. And from a research perspective, a lot of people are isolating out certain components of it to understand their effects. We can talk about that. Pluses and minuses, but from a research perspective, hard when you have, think about the numbers of possible combinations of all these things. And this is, again, not to even mention terpenes and flavonoids and other things that are in the plant. So, what you get in the market is all sorts of stuff. And this is not a buddy of mine has a great slide where he has everything in there. This is, you have plant material, which is what you typically think of on the top, but then you also have, edible products and oils and all sorts of different things that can be produced from this cannabis plant. The legal landscape is one that I always have to look at and update myself on before ever giving a talk, because I feel like it changes, between when I go to sleep and when I wake up in the morning. This is the current map, and this is just focusing on those states that have legalized medical cannabis and those states that have legalized recreational and medical cannabis laws. It seems like there's a lot that don't, but in reality, a lot of the other states, the ones in gray, have some sort of laws that are not necessarily blanket medical cannabis, but they could have CBD only laws, right? So you're allowed to use CBD oil within that state, or they have, some sort of thing. So I think all but 2 states in the United States have some form of law around cannabis, and it's constantly evolving, right? So it's an interesting landscape, and that's just the United States. Worldwide, there are countries that have legalized cannabis fully. There are other countries that are catching up there, and I think everybody's still trying to figure this out from a legislative standpoint. But what is happening, and we'll get into this within Missouri, but how these laws pass are through advocacy primarily, less so from science. And that's what we'll talk about, kind of the discrepancy there. So there, individual groups, parents, individuals that have had experience with cannabis will lobby within their states. And some state laws will also inform other states, and that's where you get these kind of list of conditions, right? That's not necessarily based on the science. So, a couple New Yorker jokes in here. So this one's a little bit blurry, but your condition is serious, Mr. Reynolds, but fortunately I scored some excellent digital for symptoms, right? So when I put this slide in this cartoon, this is an older cartoon from the New Yorker, it was like, ha, ha, ha. And now it's like standard, right? Like this is what we're talking about. Here's the problem. So from a research perspective, there's actually only very few conditions for which we actually have a decent amount of research to support use. So we have, and again, I'm breaking it down by cannabinoids, right, rather than talking about cannabis specifically. We know, and there's been a decent amount of work over the years, that THC, particularly in synthetic form manufactured by a pharmaceutical company, can help with nausea and vomiting. This is dronabinol or Marinol. We also have a decent amount of knowledge on THC's effect in pain, reducing pain. There's a company, GW Pharmaceuticals, based in the UK, that developed a formula called Sativex, which is a 1-to-1 ratio of THC and CBD, which they've shown effective and has been approved in a number of countries for multiple sclerosis. They've done some large phase 2, phase 3 trials in this area. And then most recently, also a product from GW Pharmaceuticals, Epidiolex was just approved recently for pediatric seizures, particularly Dravet and Lennox-Gastaut syndromes. And that's a purified CBD. It's an oil, essentially suspended in sesame oil. That's where our knowledge is. And it's interesting because when you look at the knowledge that we have, this is the majority of the research that's been done in kind of randomized controlled trials, and we'll talk about the other pieces of research within this. Most of this work was funded by pharmaceutical companies because this work is very expensive. When you do these trials, you're talking, for a single phase 2 trial, multi-million dollars, phase 3 trials, particularly in big conditions, tens to plus, millions of dollars per trial. And so getting even grants can be difficult. THC and pain is somewhat of an exception because this was funded by the state of California originally. They were the first state to pass cannabis laws, and they allotted an amount of money when they passed it in '96 to start a center to do cannabis research, and they happened to focus on THC and pain. And so a lot of state money has gone there. More recently, and we'll touch on this, the state of Colorado is another state that had, set money aside and has had a number of rounds of funding to fund research on better understanding the scientific, basis for the potential therapeutic effects. Outside of those, it gets a lot hairier. So from a mental health perspective, there's some data to support potentially CBD's impact on anxiety. When I say some data, we're talking about a few studies. Most of them done in South America, actually. More recently, one in Australia. But really, a handful of studies, none of these like 100-person, 200-person, 500-person big clinical trials that you need, and as part of drug development to really get a sense of whether something works relative to placebo. Not there yet, but definitely some indications that potentially there's some effects for CBD and anxiety. Post-traumatic stress disorder, this is an area close to my heart. Again, we don't know. We're just finishing the first phase 2 study of PTSD ever done, and we should have results in the next few months. Depression, potentially CBD may help with it, but most of the data there are preclinical. They're like rats in little chambers, and that's how they're figuring it out. There haven't been any human studies at all on CBD and depression. CBD and psychosis, there's been some human work. It's pretty intriguing actually. So again, here's a balance effect. So THC, especially if you have a genetic vulnerability, family history of psychosis or schizophrenia, if you use THC, you actually increase your risk of developing schizophrenia and psychosis. There's been some really interesting longitudinal studies that looked at that. CBD, particularly for those with genetic vulnerabilities, CBD, opposite effect. CBD actually could potentially, the indications is that it might actually help treat psychosis. So again, very different effects. And then, that's the mental health side, and then you go down the list, ALS, Alzheimer's, autism. There's some really cool, lots of flurry right now in the autism space. Fascinating work going on there, worldwide, Israel, in the US. Cancer, great stuff going on in Israel, cerebral palsy, Crohn's, these are all different conditions, right, for which you see in the medical lists. These are the things that cannabis is approved for. And the data are very few and far between. Tourette's, there have been a couple studies out of Germany, but when you get into, fibromyalgia, a couple studies on THC, but we're talking like 20 people, not necessarily even placebo-controlled or anything like that. Crohn's, I don't even know if there's been a human study, maybe some observational stuff in Crohn's. So this is where there's this huge disconnect, right, between the legal landscape and the scientific landscape. And part of that is just because, everybody started using it for everything. Like you go into Google and type in CBD, because that's what everybody's talking about, CBD and pick a condition, and you're going to find some story about somebody who's using it for that condition and says it works great. The problem and the reason that you need these clinical trials, right, is because we need to understand the placebo effect, right? We need to be able to demonstrate that this is effective or efficacious above and beyond placebo. And placebo effects in cannabis broadly are enormous. I can't stress this enough. When you design trials, when you go into research in this area, typically placebo effect is everywhere, right? So people believing that something's going to work and it works just because of that. In this case, for example, in the pediatric epilepsy trials, you have kids that are having 10 seizures a day and they go to 0 seizures a day and they're on placebo. That's how big of an effect we're talking about. So it's really important to be able to identify, right, whether this drug is actually better than that. With all the media and all the things out there, it can really boost placebo effect. So that's kind of the gold standard that we need to get to. As with any other drug, right, any other thing, you want to know if it actually works and you want to know how it works. So I'm going to get a little bit now into just some examples of studies across the different domains that are going on. And I'm doing this from a kind of a method of approach. So within the research on cannabinoids and cannabis, there's been, there are multiple different angles that are happening. So there are, constantly reviews coming out that synthesize the literature. I'll touch on a couple of those. There's also really interesting work going on from a product and regulatory standpoint. And then there are kind of the clinical side. And the clinical side starts out with case studies, right? Charlotte Figge in Denver, Colorado, or Boulder. And her, trying CBD, hey, it worked, it reduced her seizures, she had Dravet. This is documented in a case study, and that then leads other people to be like, hey, this is an interesting observation, maybe let's develop this and look more into this. So very important case studies on the initial level. Observational studies, right? This is a very weird space because you have people already using something that, where the research isn't there yet, and this is the cart before the horse sort of thing. I get it from some extent, but from a research side, it allows for observation, kind of this phased forward, where typically when a drug's out on market, you then see how it does out in the landscape, and you can do that now, even before some of the more foundational studies are there. Experimental studies, so kind of in lab, manipulating specific components, and we'll talk a little bit about those, as well as clinical trials, so those phase 2, phase 3 studies within this space. So an example of a review, so this is probably the most talked about review. This is a report published by the National Academies of Sciences called The Health Effects of Cannabis and Cannabinoids. This was a panel of people that got together and started talking about, went through the literature and all the different conditions, and what do we know about THC, what do we know about CBD, blah, 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 for these conditions, read through all the studies and put together this report. The problem is this landscape is changing so rapidly that even though this report was published 2 years ago, it's now pretty much out of date. If you look at, for example, in epilepsy, they say, well, there's not sufficient evidence to understand that cannabinoids can help with epilepsy, and that now we have an approved drug, right, CBD for epilepsy. So that's how quickly this can change. But it's a good benchmark and a good, you can go online, you can download it, and it's a good summary of what's going on in the space overall. We also more specifically have done, for example, and I'll plug some of my research in there just because I'm most familiar with it, specific indications. So this is a review that we put out 2 years ago, and look specifically at post-traumatic stress disorder. Like I said, that's an area of interest for me. And so we looked at what is the evidence from preclinical, so animal data, all the way up through, what is the evidence for cannabinoids as therapeutic for PTSD, and breaking it down by different clusters of symptoms of PTSD, like as up here, depressed mood, sleep, anxiety, fear conditioning, and things like that. So those are kind of the two approaches, and there have been lots of reviews in this area. And again, if you want copies of anything, just holler and shoot me an email or whatever. I'm happy to send these. There's also product studies. So this is a study. It's interesting because my area is in PTSD, and we did this study on CBD products sold online. It's got crazy amounts of press. It was a one-off, and is not really my area, but it's amazing what folks can gravitate towards. Product studies are really interesting because we have these things on the market. Right? So CBD products, THC products, whatever it is, go to a dispensary, order online, everything's available. The problem is that, and we can get into we will get into the complexities of the regulatory landscape. The problem is that there's no regulation from the FDA. And what that means is that if you have, so my basic example is, if you have an allergy to peanuts, right, or tree nuts or whatever, and you go to a store and you buy something and it says, does not contain peanuts, you know that you can probably eat that and you're all right because you have a severe allergy for peanuts. And there's a whole reporting requirement. You also know how many calories and carbohydrates and whatever are in there. That is not the case for these products. There is zero oversight. Each state comes up with its own laws to manage and regulate this space. And so what that means is, overly used term, the Wild West, but that's truly the case, right? You can create a product in your basement, put a fancy label, make a nice website, and ship it out with zero testing or anything. And unless somebody ends up in the hospital, you're probably all right. And that's a very different landscape. So in this study, tracking what's available. So these are CBD products. We essentially went out, bought every single CBD product that was available online. The criteria for inclusion was that it just had the content of CBD in the bottle. We did oils, vape, cartridges, things like that. And just as long as it said how much CBD is in it, because that's what we had to compare to see whether it's accurate, we got all these products in, blinded them, sent them to a lab, vetted a bunch of labs to find a good one, triplicate tested every product, and found essentially 70% of products were mislabeled. And we gave folks a plus or minus 10% margin of error, right? Because you have some, everybody has a little bit of room within specs. So plus or minus 10%, we called you accurate. If you were outside of that 10% range, inaccurate. And what we found, right, 70% were inaccurate, and that, which is alarming. Less so that, surprisingly with CBD, the problem is less that it has more CBD in it, though there were lots of products that had more than was labeled. The bigger concern, because CBD is relatively safe as a cannabinoid goes, the problem really for me is the lower end, right? Folks that spend $200 or $100 a bottle for the stuff and nothing's in it, or very little's in it. And a lot of times people are turning to CBD in these online preparations because it's a last resort, right? A lot of folks have had difficulties with traditional pharmaceuticals, they haven't worked, and they're like, oh, I read this thing, my friend said I'm gonna go buy this, and my kid's having, there are people with kids with epilepsy on hospice, like literally last resort. And so you wanna know that you're getting a drug that, and actually being able to use a drug that has what it says it has in it. Beyond the CBD piece, we also found that THC, there was, in a little less than 20% of products, there was THC in there, and in some cases at pretty high amounts. That's concerning. Again, not to say THC is necessarily bad for everybody, but you need to know what's in there, and none of those products have that label. There have been other studies that have come out since that have made more alarming discoveries, including other people buying synthetic CBD spiking products that are available on the market in the US, finding other benzodiazepines and other things in the CBD oils. I mean, again, zero regulation. So it's not surprising as people are trying to make money and build this up, that you have all sorts of stuff out there. It's not to say that everybody's terrible. There are some good players out here. But it's really important, to, not to go on a diatribe about this, but it's really important to make sure you're getting a good quality product. And that may mean, batch number, call the company, I'd like a testing report of this batch and lot number. They should have that. If they can't provide that, shop. If you're using it for a kid in hospice, you might want to independently test it yourself, just because right now the protection's out there for you as a consumer. So again, important research is going on in this space. That's a very different angle than your traditional clinical research. Case studies. So like I said, case studies are out here and it's really important to not only look at benefits, but also consequences, right? So we've starting to see different negative consequences associated with using certain cannabinoids. Cannabinoid hyperemesis, this is coming up more and more in the literature for folks that are using high amounts of THC. Cardiotoxicity is another one following cannabis concentrates. So this is kind of on the negative side, but positives as well. Like I said, individuals, hey, we just published, just in press, I think, a story of 3 clinical studies of clinical cases of children with Fragile X syndrome. So a very rare genetic condition, very similar to autism, who used, one used Charlotte's Web, one used something else, and they found benefit. And, they used it over a period of time and documenting that to kind of alert other researchers like, hey, so a lot of clinicians and things like that could do that to really draw attention to an area that maybe didn't study. Moving into observational studies. So again, this is a rich area because there are people that are out there using this stuff already. So here's a study that we did looking at veterans with PTSD who were using cannabis products. And this was just like, hey, let's get a landscape. What are they using, right? If you have PTSD, is this, can we use this as data to help inform, whether we should look at a certain cannabinoid or others therapeutically? So here, 70% of veterans with PTSD smoked or inhaled cannabis versus pretty low amounts of dab use, super high concentrated edibles or tinctures. And then for strain preference, most of the individuals with PTSD were preferring strains that had really high amounts of THC in it. Very few people were using CBD. And kind of surprising was that any strain bar, I don't care, whatever it is, I'll smoke it. That's essentially that bar. But interesting, right? And this is sort of the real world. This was a few hundred people with PTSD in California. Get a sense, right? Like, what is it they're using? Oh, they're gravitating towards THC. Maybe let's investigate what's going on there. Let's dig a little further into that area. So another benefit of observational studies. Another type of observational study that we're starting to see more and more of are these larger epidemiological studies. So this is these population level, what's going on. You've probably heard cannabis use, when states legalize cannabis use, opioid use or deaths or car accidents go down, things like that. Those are all these big, large epidemiological studies. This is a study that was done in the VA by my group, and this was essentially looking literally at every single person in the VA. This wasn't just a representative or anything, this was everybody, and specifically focusing on those individuals that had a co-occurring diagnosis of post-traumatic stress disorder and a substance use disorder. And we really wanted to get a sense of what is the top substance that these individuals are using, alcohol aside. And what we see here, for me, the most interesting part of this graph is up until 2008, this FY is fiscal year, is how the government works. Up until 2008, cocaine was actually the #1 abused substance among folks with PTSD. Fascinating, I think. Seems a little contraindicated, but for a lot of other people to research. But you see after 2008 or 2009, and this coincides, right, with a lot of these medical cannabis laws. Even though 96 was when California enacted the laws, it wasn't until 09 or so that it actually hit the ground. We see cannabis, right? #1, skyrocketing up in the air. You can flip this. There's some really, we flipped it and said, what's the, among all people with a cannabis use, disorder diagnosis, what's the primary condition that they have, psychiatric condition, and it's post-traumatic stress disorder. So kind of bi-directional, really interesting. It would be great to just get cannabis use data, medical cannabis data, but the VA only tracks problems associated with use, and so this is the closest that we have is from a substance use disorder perspective, which we'll talk some about as well. And then there's group comparison data. So this is some more recent data from a registry done in Colorado. This is cannabis and autism data. Again, very fascinated with this. I think this is cool. Here we have cannabis users and non-users, all with autism, and we're looking at a number of different measures to compare, right, where we see potentially, improved symptomatology in the cannabis using group versus the non-user group. So in this case, quality of life, sleep, anxiety, and depression seem to be lower, or better, if you will, among those that use cannabinoid therapy or cannabis therapy relative to non-users. And some of this, along with other data, is what's again getting larger companies and big funders to come in and say, hey, let's put some money behind this and try to figure this out. So again, really important to these observational studies to get a sense of trends that are going on. And then we also have prospective observational studies. So this is a little peek at some data that we're doing, a study that I have currently ongoing, wrapping up in Colorado, where we're looking at individuals with PTSD. Half of them users of cannabis and half of them non-users of cannabis at the start of the study. And we're following over the course of a year. Every 3 months we're assessing them and we're really trying to see what are the differences in symptoms over time. And more interesting to me is what happens when they change groups, right? So I don't care, at the start of the study, half, 75 users, 75 non-users, all PTSD. But some people who started using, they stop for whatever reason, and some people who weren't using, they start. And you can see kind of the impact of starting use naturalistically on their symptoms. And then at every 3 months, we're also testing the cannabis that they're using. The top 3 things that they're using, we're sending off to a lab to get independently tested so we can get a sense, again, of not only what's their trajectory of symptoms, but how does what they're using and choosing to use impact that trajectory, again, to help think forward towards these clinical trials. In this case, it was kind of interesting, right? So capped total severity, this is overall PTSD symptoms. What we see is that cannabis users had a lower PTSD, even though they started about the same, over the course of a year, they had lower PTSD symptoms. It's about a 5-point difference. That's still clinically significant. So interesting, right? Over the course of a year. We're still digging into this. I'm going to Colorado not long after this to dig into this some more. And then if you break down types of PTSD symptoms, we find negative alterations in cognition and mood, and arousal and hyperactivity and reactivity being some of those that are driving this effect. So again, helps us better understand what's going on and a sample of some of the research that's going on in this space. Is this really all we have? No. So we're going to move now into the experimental stuff and the clinical work. But again, just as you note, and we'll talk about this from a regulatory perspective, this work is incredibly complicated and difficult, and it's driven a lot of folks out of the field just because it's so difficult. So cannabis, even though it's legal in your state, and the reality is cannabis is a Schedule I substance still from a federal perspective, which means that if you were to do a study on cannabis, even if it's something you could go to a dispensary in Missouri and buy, if you want to do a study of it and administer it to folks, you actually have to get a Schedule I license from the DEA. You have to get cannabis from the University of Mississippi, which is the government source of cannabis. You have to have a safe that you put it all in. It has limited access, security cameras. You get inspections, pop inspections from the DEA. So, it's a mess. And it makes it very, very hard to do this research. You have to have, I'm always fascinated by work on grit, because it feels like you really need a lot of grit to do this work. And, it's a pain. So to give you an example, just try to play a little interactive here. So THC, so substances have different schedules, right? So it's 1 through 5. 1 is illegal, no medicinal benefit, highly addictive. Schedule 2 is a little bit less so, all the way through 5, which is low to no addiction potential and medically benefit. Where does THC fall in this? So Schedule 1, Schedule 2, Schedule 3, all of the above or none of the above. Any, raise your hand, throw a hand number or something. Any thoughts? 1? So actually, cannabis is in all of the above. And this is how screwed up the DEA is right now. And I'm not, I used to work in government, I get it, but not quite with this. So in Schedule 1 is THC from the cannabis plant. In Schedule 2 is a synthetic formulation of THC that's taken orally called Syndrose, made by Insys Therapeutics. And then Schedule 3 is dronabinol, which is also a synthetic THC. even though the molecule is identical between each of these, it happens to be scheduled in 3 different stages. So schedule 3 is just dronabinol. Even though syndrose and dronabinol, 2 and 3, are literally almost identical. The difference is the liquid that it's suspended in. You have a difference in schedule. So it doesn't make a whole lot of sense. Yeah?
And do you think that's more of a political difference, or?
Well, some people thought, syndrose got knocked to Schedule 2 because INSIS had a whole bunch of issues in the fentanyl business that you've probably seen on the news. Maybe somewhat political. A lot of times, the government will do scheduling specific to a given product. And the weird part here is that, everything else is this catch-all of Schedule 1. But I'm sure politics are part of this, and it's a dance. The FDA does a review of the literature, gives a recommendation to the DEA, and the DEA can either accept or reject that. So here's the example, right? So CSA, SCH is the scheduling, marijuana, Schedule 1, dronabinol, Schedule 2, dronabinol, and sesame oil and soft gelatin capsule is Schedule 3. Wild. So that's the fun of cannabis research part of it. CBD. So you hear CBD, right? Everybody's got CBD. I saw a billboard driving in this morning. CBD, what did it say? It was something like, we've got it 8 different locations or whatever, gigantic sign, driving from St. Louis in here. Is CBD Schedule 2, 3, 4, all of the above, none of the above? Where is CBD in this space? Is it the same as THC? What do we got?
After the farm bill, doesn't it? It's not a journal already.
So you say none of the above?
Yeah, none of the above. I think farm bill said treat it like corn and soy, right?
That's what you think. But in fact, the answer is, it is, it's none, so the answer is none of the above, but not for that reason. So the reality is, CBD is Schedule 1, Schedule 5, and unscheduled. And it's all about the source. So if CBD from cannabis, CBD, so derived from cannabis, synthetic, any other thing, Schedule 1 still. Epidiolex, product from GW Pharmaceuticals for pediatric seizures, Schedule 5. CBD, purified CBD, same thing, it's Schedule 1 for everybody else. And the Farm Bill, hemp-derived CBD, unscheduled. So literally the source, even though the molecule is identically the same, the source dictates where it falls. And so a lot of people thought exactly that, which is a good point. Hey, Farm Bill passed, which is this new thing, passed the legislature, Farm Bill passed, CBD's unscheduled, we're good to go across the board. And all of us doing research with many different sides of it that aren't hemp-derived are like, really? We're still in Schedule 1 after all that? And that continues to be the case. So it's a really messed up landscape from a research perspective. So let's talk a little bit about some kind of fun studies. So this is a colleague of mine at Hopkins, Ryan Vandry. So this is an example of these experimental work that can be done. Really cool stuff. I mean, he's a fun example of this because he does pop brownie studies, he does hot box studies, all sorts of cool stuff, all experimental. So here's a study where they gave individuals 25 milligrams of THC, so a pretty decent dose of THC. Smoking, vaping, or oral administration. Oral is in brownies. And here, looking at the THC level in the blood over time following use. So you see, the kind of take home from this is, oral and vaping, you have pretty quickly, you have a high effect, right? That's smoke a joint, get high quickly, if you're high. But you see if it's oral, not only is it a delayed effect, but it's really shallow in terms of actual, even though the same amount of THC is being delivered, way lower PK. And then drug effects, which is the other one, which is missing a y-axis. The drug effect on the other side, you see that they actually have, oral drug effects can be almost as high as smoking and vaping, delayed, but you don't have that level in your blood, right? So you can be stoned out of your mind, but you're only popping up at 2 nanograms per ml, you would pass a drug test, even though you're just as high as you were when you know what I mean? So these are the sorts of complexities, and the cool things about doing these experimental studies is playing with these factors and tightly controlled studies where you can manipulate these pieces and really look at these drug effects.
Are drug effects just self-reported?
Yeah, so these are, how high do you feel and things like that. Yeah. But you can manipulate that. Or you can have people do tasks, there are people who do driving tasks and other ways to do it. Clinical trials, so this is, kind of my bread and butter in this space as of late. So this is kind of one of the big studies by GW Pharmaceuticals on dialect. So this is a large trial. They're using, numbers of people that are coming into this. And they're looking at the effects of administering, this is an open label, looking at the effects of administering CBD to individuals with veterinary and non-extremist. And looking at side effects, looking at efficacy, etc. On the flip side, here's a study on negative comments. So like trying to find out whether dronabinol, so this is synthetic THC, can be helpful for treatment of cannabis dependence. So can we, isolate out specifically and help, get people off of traditional cannabis by just giving them one active ingredient, potentially at lower doses, and reducing risk. So again, these kind of larger clinical trials are ways, comparing it to placebo, as you see in this nice graph. Take home is actually doesn't do too well, does all right, but not too well. Dronabinol versus placebo over time. Let's try. One of my more favorite, not a horse, but a cat, dynamite rat. So the flip side. So this is all kind of the painting the landscape of the therapeutics. It's complex, right? If you want to talk about given conditions, it's hard to cover everything in a short period of time, but that's kind of painting the picture of how researchers are coming about it from each of these different angles. But there are also consequences to consider. This is where this used to be what I did a bunch, and most cannabinoid researchers, honestly, in the therapeutic space used to do consequences work because that's all that you could get funded, and now everybody's funding cool therapeutics, which you all want to do, and now are doing that. This is a lot sexier and more interesting. So negative consequences, some of these have been, there's been pushback on some of these, but I feel pretty confident in most of these. Short-term use, we know that cannabis, particularly THC, can impact short-term memory, motor coordination, altered judgment, and increasing risk of risky sexual behaviors and STDs, particularly in women, actually. And in high doses, particularly with individuals that have genetic propensity to it, can lead to psychosis and schizophrenia. Actually, it's pretty interesting literature there. Long-term use, we know that, and I'll get into this in a second, long-term use of THC, and this is cannabis, but really it's THC that's driving these effects. Addiction, altered brain development, poor educational outcome. This is where some people can get up in arms about it. Some cognitive impairment, diminished life satisfaction and achievement. Again, it's for debate. Those are the stars if you want to get into that. These aren't my claims, but symptoms of chronic bronchitis, and again, increased risk of chronic psychosis over time. So those are kind of a broad painting of the negative consequences, again, mostly associated with THC. That's where, the work more recently on CBD, which is, the second most studied, not a whole lot of negative consequences. Most of the adverse effects from the studies that are out there are things like somnolence, GI issues, partially because it's suspended in sesame oil, and you're drinking a whole bunch of sesame oil, and it's going to cause some GI issues over time, things like that. But you don't see the addiction potential or things like that, or impairment. In fact, some early data are showing that CBD may actually improve cognition over time. Is there a question there?
Go ahead. Just to clarify,
Sure.
Are these symptoms, you said they're of THC, are they of THC as a chemical or like inhaled, ingested?
Yeah, typically for these studies, most of it is recreational, like what you would call recreational cannabis use, smoking it or whatever. It's not a synthetic. Most of these will say cannabis leads to this, but really later research has said it's THC that's driving these effects, not cannabis.
So bronchitis could be maybe more too. inhalation of smoke rather than necessarily the THC itself.
Potentially, right. I mean, there used to be some literature that showed that cannabis can lead to lung cancer, for example. And there was a bunch of work, and Donald Tashkin, a guy who did some of this work and kind of later went back and said, no, actually it was driven by tobacco smoke. A lot of these people use tobacco, and that's what was causing the cancer problems. If you isolate the tobacco cut down, it actually did them. So things like that are really important nuances here. Absolutely.
Same question.
Okay. Yep. So kind of another, so this is so bringing the kind of some of the things we talked about in terms of study design and consequences together. This is a study we did in California at a dispensary in San Francisco. This was a cross-sectional study looking at adults and asking them about a number of reasons why they use cannabis, consequences of use and things like that. We recruited about 200 or so, primarily male, pretty well educated, primarily white Caucasian, middle adult, I guess, or what we call it in bracket. But pretty representative, here's the education piece, pretty representative of the population in San Francisco. We don't focus too much on the demographics, but if you ask them why they use cannabis, these are the top reasons that they use, top 10 reasons that they use cannabis. Number one was anxiety, number two is chronic pain. There are lots of studies that have come over, this was a number of years back now, lots of studies that have come out afterwards that have try to document why people use cannabis. And it's usually anxiety or chronic pain fight for number one and number two, depending on where it's done. Stress, insomnia, depression, appetite, headaches, all the way down to PTSD rounding at the top. Yeah.
That's just people who say they're using it for medical reasons?
Correct. These are medical cannabis.
Fun would be the number one.
Fun?
Well, reasons why people are using it.
Yeah, so there's definitely fun. So this is before recreational passed in California. Okay. So this was when medical was there. So people needed conditions. And there's some of that, right? But then there were legitimately, and I think a lot of people were using it for one reason or another. Though, your point's well taken. I mean, there are people that are just using it to have a great time, right? And that's out there. And I think it's a lot of times what you find is people use for lots of different reasons. Right? They're not just using for this. It's like, oh yeah, I'm using it for pain, but I don't mind the high, or whatever it is that's part of this. But when we ask them what are the primary conditions, and again, as you see, these numbers don't add up. They add up well above 100% because people are using for multiple reasons. Getting back to the consequences piece, so same symptoms on the left-hand side, then we actually had assessed them for whether they met criteria for cannabis abuse and dependence. So this is, do you have a problem with your use? And this, these are standardized criteria, which we'll touch on in a second. But this is, a large percentage, so I don't know if it's a little bit difficult to read. So the number of people, I would focus more on what's within the parentheses, that's the percentage of the sample that met. So in the total sample, 20% or so had a problem with use. That means, they may develop tolerance over time, they may have difficulty stopping use when they need to stop, they may crave the drug when they're not using, things like that. Experience withdrawal symptoms. So, and here as you look down the different conditions, there's some conditions that are associated with greater risk of problems than others. And part of that may be what it is that they're using. We also know this is a different study looking at individuals with cannabis problems with and without PTSD. And we found that individuals with PTSD were more likely to have problems associated with cannabis use, more likely to experience, this is kind of a terrible thing to put up here, I should have a nice pie chart or something. More likely, so people with PTSD more likely to use to cope with negative affects, so negative experiences, more likely to have problematic use patterns, more likely to experience withdrawal. Right? If you stop using, even for a short period of time, they're more likely to have these symptoms like anger and irritability, sleep difficulties, things like that. And they're more likely to crave cannabis during times of cessation. So what do? You have lots of people using it, right? Some people having problems with use. There's work that's trying to figure out how do we get them off, right? How do we overcome this? And the reality is we haven't figured it out yet. And again, people can stop be interested in stop using for a whole host of reasons. Of course, the naysayers would say that, why would you want to stop using? The only people that are wanting to quit are people that are court mandated to quit, or people that are, adolescents in treatment programs and things like that. Heard that. The reality is, though, there are actually a lot of people that do choose on their own to quit. And for those folks that do, it's quite difficult. Relapse is extremely common. With our top treatments, 63% of them relapse within 4 months, 72% by 16 months. Here are a couple stats from a couple of different things. Here's a nice little graph. Percentage of participants with continuous abstinence, so being able to stay off, either receiving cognitive behavioral therapy, that's the red, contingency management in the green, or a combination of cognitive behavioral therapy and contingency management. Again, top treatments that we have for substance use disorders broadly. They work a little bit in the beginning, but they don't last that long. We find a lot of people relapsing back to use. Why? Well, a whole bunch of different reasons. Physical activity we found as one predictor. So, the less somebody exercised, the more likely they were to relapse. Sleep difficulty. More difficulties with sleep. Not too surprising, sleep difficulty is a symptom of withdrawal. So you stop using, you start having nightmares, you start not being able to go to sleep, things like that. That will then predict relapse. And positive expectancies. You think cannabis, can help with all these different symptoms. The more positive you are about cannabis, the more likely you are to relapse. We also know that individuals with PTSD, so this is a study, individuals with PTSD in orange, non-PTSD in white. Those with PTSD, particularly over the first 4 weeks, have a greater difficulty quitting use, though if you measure them over the course of 6 months, they fall. Why is that? Partially because the withdrawal profile of cannabis lasts about 4 weeks. So, clinical landscape. All right. So that's negative, right? Now we're kind of moving into, from a clinical perspective, what are we dealing with and how are we increasing the clinical side? We recently finished a study, I think this is in press, where we surveyed physicians. Right, so these are the folks that are on the ground, frontline, interacting with individuals that come in for whatever. These aren't necessarily physicians that are working from a cannabis perspective, but we're trying to get a sense of how equipped do physicians feel as they enter this space, right? Because this is a really complex space, it's ever changing. We have, kind of the work that's gone on the longest is that of negative consequences, which we'll review in the second half. Then we have this emerging domain of therapeutics on the front end. There is no consistent training. There are a few programs that are starting up. One's at Thomas Jefferson University, one's the Answer Page, and a few others that are really trying to build up education for physicians in this space to kind of keep them abreast of what's going on. Because most of them get training in cannabis is bad, right, across the board. And we need to update that, right? We need to give them a nuanced perspective. We need to tell them that CBD is very different than THC. THC can be helpful for some things, but we've got to moderate it a little bit and watch out for these negative consequences associated with it. So we have looked at physicians and asked them about this stuff. And interestingly enough, and again, I'm not good at presentation of data, what we found is that very few physicians are actually formally assessing for these, for problems associated with use. Very few physicians believe cannabis is safe for use. Very few physicians think that cannabis may be helpful, particularly for post-traumatic stress or anxiety. This is the focus of this. And very few, right, prescribe cannabis for PTSD, suggest trying cannabis for PTSD, trying cannabis for anxiety. You see the numbers, right? Incredibly low, right? And part of this is this just hesitancy, right? How much formal training and how much interest in formal training. Some of them said, well, I've been trained some, but a lot of them also said, I would love more training in trying to understand what this is. And so this is the problem in this landscape. Right? This is an area that is so quickly evolving. And doctors in the traditional sense, right, are hesitant to embrace it. And understandably so, right? They're looking for clinical trials. They're looking for dosage data. And as you see, as we've talked about, this is quite complex, right? So if somebody comes in who have, anxiety, when you walk into a doctor's office that may be prescribing or recommending, whatever you want to call it, cannabis, what do they say? Go use cannabis. Well, no, right? If you use THC, you might actually get worse, especially at high doses. All likelihood, if I put the money on the table, I would say your anxiety may get worse over time. You probably want to steer somebody towards CBD, right? But they don't know that. And so, and how much do you tell the patient to use, right? What's the dose? What product, right? We don't even have a regulated product, with the exception of Epidemiological. So that's, this has caused lots of hesitancy, this whole landscape from a clinical picture. Also, just from a just broadly medical setting, it's the tracking of problems, the assessment of problems, the assessment of use is not there to where it should be. So this is a study that we did in the VA, took a sample of individuals, all of them had problems with cannabis. That's the white bar. How many of those had cannabis use disorder diagnosis in their medical record? 22%. So that means, right, that we're missing a huge gap of people that are just not even getting tracked, not even getting assessed, right, that have problems, that are struggling with issues, not making it into medical record, not making it, right? That's an issue. Also, kind of surprisingly to me, because this is the Department of Veterans Affairs, 36% of our sample had PTSD and only 21% of those had any medical records, just an aside. But again, this is a problem. We need to be tracking this stuff. And there are easy ways to do it, right? This is a measure, so for problems associated with use, this is a measure, the Cannabis Use Disorders Identification Test, developed by a group down in New Zealand. 8 questions. Decent confidence, fill out these 8 questions, gives you a score. The score falls within X and Y. You have a decent likelihood that this person's struggling or having difficulty with cannabis use. Easy enough to do. We actually even shortened. Maybe 8 questions is too much. Primary care, right? 8 questions may be too much. We got it down to 3. And with similar sort of validity in terms of identifying individuals that have problems. Again, don't need to always focus just on problems, but even tracking use, right? Largest healthcare system in the United States. VA, no tracking of medical cannabis use, no tracking of legal use.
If you report cannabis use in the VA, don't they mandate treatment then?
Yeah.
They don't?
Nope. And that's part of that is the misconception, right? A lot of people are scared. And in fact, in the past, the VA, if you were receiving traditional health care and you said you used cannabis or something like that, then weren't allowed to see, some services were withheld from you. That's what they say. That is no longer the case, thank goodness. But it's still, there's stigma, right? And, there are improved treatments. So, here, this is a, Studi Back's treatment for, there are treatments that are getting better at trying to address individuals with cannabis that have co-occurring psychopathology that can help increase the odds that they have difficulty. So where do we go from here? Now that it's always bad to stop in a negative, right? All these bad things about cannabis, because the truth of the matter is there's lots of great things about cannabis, and I'll tell you a little bit about some upcoming research that we're doing, looking at those therapeutics that we talked about on the front. So there's a study that we're just finishing. We just had a meeting about it 2 days ago. Individuals with PTSD. What we did is we administered randomized, this is a crossover randomized double-blind placebo-controlled trial, where individuals come in, PTSD, they get randomized to one of 4 groups. Again, looking at the nuances here of cannabis composition, high THC with very little CBD, high CBD, very little THC, a 1-to-1, and a placebo. Get randomized to one of those groups, use it for 3 weeks. So we're looking at acute symptomatology. They stop, we look at withdrawal, right? Does their symptoms get worse after they stop using it? Then we re-randomize them to another group, and they use a different one of those conditions for 3 weeks, and then they stop for 2 weeks. And really looking at the impact of, again, this 1-to-1, high THC, low CBD, high CBD, low THC, or placebo on PTSD symptoms, including suicide, psychosocial functioning, quality of life, and also negative consequences, right? Are there certain groups that have more negative consequences than others during times when they stop? This is being conducted, just finished being conducted in Arizona. We're also doing a replication study on Canada. So the one in the United States is focused on veterans, military veterans with PTSD. But of course, with that comes, these are primarily male, primarily combat-related trauma is what we've focused on. But there's lots of other people with PTSD, right? Lots of women with PTSD, lots of other types of trauma that are very important to track. We also use smoked cannabis in this study. So actually, literally gave them cannabis flower every day, up to 1.8 grams per day that they smoked. There are better ways to use it, right? Vaporizing cuts down on some of the carcinogen pass-through and things like that. Maybe more efficient as a route of administration. So in Canada, we're using vaporized, and we're looking at more women and individuals, first responders and sexual assault victims and things like that, to see if we see similar sorts of patterns. And that study's staggered back a little bit, but catching up. So that's cool, right? And that's going to, over the next few months or so, I have to start rigorously writing on this one. We'll be releasing the results from that study and really being able to dig in on whether there is. So again, cannabis is not cannabis, right? Is there a certain preparation that's helpful for PTSD symptoms better than another preparation? What I'm most proud of, and I love mentoring and training students, so my former student, Mallory Laughlin in San Diego, she was my postdoc, and now she's faculty at the VA in San Diego, just received the first cannabis administration grant from the Department of Veterans Affairs. Big step forward. I was there for 10 years jumping up and down, and she got it, which is awesome. And she's going to be looking at CBD as an adjunct to prolonged exposure. So prolonged exposure is kind of like the traditional behavioral therapy for PTSD. One of the top gold standard treatments. This is bringing somebody into a session, talking about the trauma. It can be pretty distressing at times, but it works. But it also has high rates of attrition and things like that because it's intense. It was developed by NFOA, who's in Penn actually as well. The thought is CBD can actually, it appears, can help with extinction learning, can help dampen some anxiety, and it may help along with prolonged exposure to help increase the likelihood that it works and the speed at which it works. So we're doing this study where we're looking at prolonged exposure or prolonged exposure plus CBD, if that makes sense. Prolonged exposure plus placebo versus CBD. Again, first cannabinoid administration trial funded by the VA, so kudos to the VA for getting on board. 136 military veterans. Again, that's the breakdown. We're looking at 600 milligrams of CBD a day. That's, from a clinical effect, and we can talk about this, wellness use of CBD is pretty low, right? If you look at cannabis infused, or CBD infused coffee, CBD infused matcha tea, CBD infused pickle, salsas, I've heard it all at this point. They have pretty low amounts of CBD, 5 milligrams, 10 milligrams. When you buy even some, popular products, an entire bottle may have 500 milligrams. And you spend $100 for that bottle. So, and the reason is, so there's kind of the difference between that and what's been shown clinically as effective. There have been studies that looked at different doses for actually moving clinical effects, reducing anxiety, improving, the epilepsy studies, they were starting at 5 milligrams per kilogram up to 20 milligrams per kilogram. Think about how many kilograms you weigh, it's a lot of CBD. For here, part of this was based on social anxiety. 600 milligrams was shown to help with social anxiety. And that's part of what informed some of the dosing. A lot, relatively as opposed to traditionally. Primary outcome CAP, so again, PTSD symptoms, also tracking kind of more granularly PTSD symptoms weekly with the PCL, and then looking at side effects and things like that. So that's starting, that's actually the data updated this slide. It initiates spring of 2019 because it got pushed back with all this fun regulatory stuff that I talked about before. It takes a year to get this stuff off the ground just from all of these approvals. So I will leave it there. Open it up for questions. We can go, as long as low as we go.